Good morning everyone, I am Dr. Jitendra, Assistant Professor Neurosurgery. So as per the topic decided previously, now we are discussing physiology of CSF flow and clinical feature investigation and management of raised intracranial pressure, hydrocephalus and intracranial space occupying lesions. So I have divided for today's class in these headings, subheadings. First we are going to have about the historical background, then CSF anatomy and physiology, pathways, functions of CSF, intracranial pressure and CSF dynamics, then investigation and then management of particular diseases. So first, Hippocrates found that there is a fluid in the brain that after decades or years known as cerebrospinal fluids. Then the Galen finds that there are some cavities that called ventricle inside the brain, and the Vesalius found the flow of the CSF from the ventricle to the spaces. Then McGinty was the first who performed cisternal puncture in animals, and Kink was the first to do the lumbar puncture, and Kinsted was first to do cisternal puncture in humans. Dandy was the first person who did ventricular puncture, and Mixter who do the endoscopic third ventriculostomy. So this is a short about the historical background about the CSF flow. So in anatomy and physiology, you very versed about what is the intracranial volume, CSF. So cranium is a closed cavity. Inside that there can be three things: brain, CSF and blood. So the average cranial capacity of human is 1400 to 1700 ml, and approximately 10% is occupied by the CSF. Usually 150 ml, 140, 150. Then the rate of formation is 0.3 ml per minute, that is 20 ml per hour, 500 ml a day, that is CSF form and resorb, and the human can have 3 to 4 cycles per day of formation and absorption of CSF. So where the CSF formed inside the ventricle. Inside the ventricle, they are choroid plexuses. The choroid plexus are covered by ependymal membrane of ventricles. The CSF formed by the active process and the passive processes. Approximately 70 to 80% was formed by choroid plexus, and other 10 to 20% by ependyma of the ventricles. This is a diagrammatic representation of ventricle, lateral ventricle. This is a lateral ventricle, this is frontal horn, this is atrium, that is a temporal horn, and this is the choroid plexus. These are two lateral ventricles that opens in third ventricle, which again open in fourth ventricle with aqueduct of Sylvius. So we can have choroid plexus in both lateral ventricles, then roof of third ventricle, and then roof of fourth ventricle. These are the major sites of major formation of CSF. And choroid plexus are the plexus of the vessels, so they are going to have a supply from arterial systems. So this is a lateral view of that previous slide, that is a lateral ventricle that opens in third ventricle, which eventually open in fourth ventricle via aqueduct of Sylvius. So these are the choroid plexus which are supplied by anterior inferior cerebral artery or the posterior inferior cerebral artery. Major supplies are come from these arteries. So, what is the mechanism of formation? This is a histological pictorial diagram for a ependyma lining the choroid plexus. This is a vessel of choroid plexus that is lined by ependyma. Ependyma is cuboidal epithelium and ciliated. So, blood flow inside this choroid plexus and CSF is secreted as the active process of the processes. This is a cellular level diagram how CSF is secreted. The major part is of CSF is water. That is, water is actively secreted to the by the aquaporin 1, and another major part is carbonic hydrase. The CO2 in water in the presence of carbonic hydrase converts into hydrogen ion and bicarbonate that is secreted. Glucose is also a major component that transport from the GLUT1 transporters, and then sodium potassium are through the sodium potassium chloride co-transporters. So, here is the pathway of CSF flow. We are going through the anatomy of CSF flow. So, as I previously said, now we can discuss. There are two lateral ventricle that opens where the foramen Monro into the third ventricle. This is third ventricle. Lateral ventricle lies in parasagittal plane, so it is not visible in this mid-sagittal plane. So, from the lateral ventricle through foramen of Monro, CSF enters the third ventricle. From the third ventricle, it flows to the fourth ventricle from the aqueduct of Sylvius tract in the midbrain. From fourth ventricle through the opening of foramen of Monro and Luschka, it come out into the CSF subarachnoid space, and then first flow down and then come upward to the arachnoid granulation where it goes absorbed passively. This is the posterior surface of brain showing cerebellum and brainstem with the opening in midline, that is foramen of Monro and two foramen of Luschka. Sorry, foramen of Magendie and foramen of Luschka. Again, for the simplification of the previous slide, the CSF flow from lateral ventricle to the third ventricle, from the aqueduct of Sylvius to fourth ventricle to the foramen of Luschka and Magendie to the subarachnoid spaces. The subarachnoid spaces are called as cisterns. Cisterns are the fluid-filled spaces which are divided by membranes and have a specific opening. So, cisterns are arranged in subarachnoid plane like a bread, packet of a bread. They align side by side but have a specific opening. So, the CSF can flow from one compartment to other compartment. This is MRI a depiction of that diagrammatic representation of CSF flow. It is the lateral ventricle to the third lateral ventricle to the third ventricle to fourth ventricle. Then CSF comes in CSF cisterns such as medullary cisterns, pontine cisterns, and prepontine cistern, ambient cistern. These are the fluid-filled spaces of CSF that has specific openings for the CSF flow. The mechanism of flow. The oldest theory is through the pulsation of the arteries. So, the CSF present in the ventricle with the pulsation of CSF, there is the mechanical pressure over the ventricle. So, the CSF flow in the direction from lateral ventricle to third to fourth ventricle, and that is the Cornwell hypothesis. And the other one is venous hypothesis for Dreher and Kolaczewski. They said that the negative pressure built in the vein cause flow of CSF in the ventricular system. These are the old theories to explain the flow of CSF, why CSF flow from lateral to third to fourth ventricle, then to subarachnoid space and get absorbed. It is due to the pulsation created by the arteries or the veins that cause pressure in the intracranial pressure, negative pressure, that positive pressure that lead to the flow of CSF. Other are the classic one that were given by Cushing, the dandy. It is due to the bulk of the CSF, it flow down due to the gravity, but it do not explain how CSF flow in supine position. It is based on the dye studies done when the dye is injected inside the ventricle, and it shows the flow from the part as we discussed from lateral to third to fourth ventricle. Then the hydrostatic pressure gradient theory of Bergman, the gradient of the pressure between the ventricles and subarachnoid spaces. As I said that subarachnoid spaces is a cisternal spaces that have different cavities without opening but having different pressures. So, that differentiation in pressure cause gradient and cause flow of the CSF from ventricle to cistern to direct then to the arachnoid granulation for absorption. Then another theory was intracranial compliance theory. It is that we discussed in Monro-Kennedy hypothesis that in brain there can be three things: the brain, blood and the CSF. So, there is a compliance for the fluid in the brain that cause gradient to flow, and new latest one is the glymphatics theory, that is same as a lymphatic system in the body that cause flow of the extracellular fluid that cause gradient that ultimately lead to the flow of CSF. So, this is at the terminal level. After CSF came out either via two-way from the foramen of Magendie of Luschka to the subarachnoid space, or from the central canal at the tip. Both CSF go first downward and then rise above and came to the vertex of the brain, where arachnoid granulation tissue is present around the sagittal sinuses that cause this is a coronal section cut through showing the sagittal sinus. This is the midline of body showing sagittal sinus and two half of the cerebellum. In between there is sagittal sinus and falx cerebri. The arachnoid tissues get granulated and pouched inside sinuses. So, the CSF space in this is a space where the CSF flow. The CSF goes inside the sagittal sinus, from where there is a gradient for the CSF to get absorbed through the sagittal sinuses. That this is the technical diagrammatic representation how the outpouching of the granulation tissue inside the sagittal sinus lead to the gradient dependent flow of the CSF to the sagittal sinuses or the venous spaces. the pressure inside the dural sinus is less than the subarachnoid space. So, there is a gradient to flow of the CSF from the subarachnoid spaces to the blood filled spaces, venous spaces, that are called sinuses of the brain. So, what are the functions of the CSF? As we can see, the major function is to protect and support the brain. It provides a cushioning effect to the brain. It acts as a shock absorber and maintain the homeostasis inside the cranial cavity. That it removes the waste products, provides some of the glucose for the utilization, and immunoglobulins for immunity. And what is the intracranial pressure? The pressure inside the cranial cavity is intracranial pressure. In a young adult in erect position, it is about in supine position, it is about less than 15 mmHg, but it depends on the position and different phases of respiration and different phases of cardiac cycle also. So, in supine position, it is usually less than 15. More than 20 is alarming. What we are going to learn in next slides about the pathology, where the ICP is raised. How first the value is 20, now we consider it at 22 mmHg to be considered as raised intracranial pressure. So, in supine position it is 15, in erect position it can be negative, in sitting position it is about 5 to 10 mmHg. From the Monro-Cayley hypothesis, we can understand that brain parenchyma occupies 80% and CSF occupies 10% and blood compromise about the 10% for this intracranial pressure and content. What is the compliance? It is the relationship between the changes in volume of intracranial content and changes in ICP. From the Monro-Cayley hypothesis, that inside a cranial cavity only three things can remain, that is the brain, CSF or the blood. So, in case when a component, usually the blood, increases, it leads first to shift out of the CSF and then mass effect of the brain. So, for autonomic function, there must be a compliance, so that this CSF can have their space and percentage in the cranial cavity. So, the compliance relationship is non-linear. As we can understand from this graph, there is non-linear relationship between the volume of pressure, volume or the pressure of CSF or the blood lead to decrease in compliance. So, with increase in ICP, there is sudden shoot up which lead to the shift of the CSF for the autonomic balance. Compliance decreases as the combined volume of the intracranial content increases. So, this is the Monro-Cayley hypothesis. You are very versed from that. That is the normal. This is whole representation of the cranial cavity. So, 80% part is occupied by the brain, then 10% by arterial volume, then it is a part of blood, that is the venous volume, and green one is CSF. So, for changes in the content of the cranial cavity, there must be some autonomic regulation which lead to decrease in most common shiftable components such as CSF and blood. So, in a cranial cavity, if with brain and the arterial volume there is a bleed or a mass that occupied a component of the volume inside the cranial cavity, this lead to decrease in the volume of CSF and the venous volume. And this is showing the decompensation of the increased ICP, as there is non-linear relationship between the compliance in the volumes. So, with increase in the mass, there is sudden decrease in the volume for the CSF and the veins. Factors that influence intracranial pressure, that we know: the arterial pressure, venous pressure, intra-abdominal pressure and intrathoracic pressure, posture, temperature, blood gases in ABG, hypoxia or hypercapnia. The degree to which these factors increase ICP depends on the ability of the brain to accommodate the changes. So, the intra-abdominal and intrathoracic pressure indirectly from the plexus of veins inside the spinal canal transmit the venous pressure to the cranial cavity, and posture, as we know that in supine, in an erect position or in sitting, there is changes in the CSF pressure, and then the temperature and the blood gas. Hypoxia and hypercapnia. Hypercapnia increase the volume of venous blood flow, and hypoxia cause constriction of the arteries inside the brain that can lead to changes in the intracranial pressures. So, this is the most important thing is what is cerebral perfusion pressure. It is the minimum amount of the pressure that is required for the flow of arterial blood in the brain. This is we have to maintain. If we at any time if we fail to maintain the cerebral perfusion pressure, it can lead to disastrous complication in the patients. So, what it could be? It is the cerebral perfusion pressure is mean arterial pressure subtracted by intracranial pressure. So, mean arterial pressure can be 100, and if we consider erect or the supine position of the subject, then ICP could be 15, and 70 to 80 is the normal cerebral perfusion pressure that we have to maintain. Otherwise, less than 50 will lead to the cerebral ischemia, and less than 30 is brain death. These all changes are irreversible. We cannot reverse it after 5 minutes of CPP less than 70 mm Hg. So, this is the most ultimate goal we have to achieve while studying these CSF pressures, intracranial hypertensions, hydrocephalus, or the intracranial space occupying lesions. So, CPP we have to maintain in any condition at any cost. So, what is the normal composition of CSF? We all know that cells could be up to 5, and mostly it is lymphocytes. Protein can be 15 to 45 milligram. It depends. In later slide we are going to read about what are the composition in different stages or diseases. Glucose is approximately 1/3 of the serum glucose. Chlorides is little more than the blood, that is 116 to 120. Sodium is almost near about serum level, that is 170 to 137. Potassium is a little higher than the serum, that is 2.3 to 4.6, and osmolarity is nearly about the serum, and density is about 1.0005, and pH is it is more acidic than the blood. So, here is a comparison. So, sodium is little bit on the downside, potassium is on the downside, bicarbonate is almost equal, PCO2, and the pH is little bit on the acidic side. Osmolarity is near about same, and CSF is 2/3 of the blood glucose. So blood, to diagnose any disease, we should have the values of the serum glucose to compare it with the CSF. It is usually must be more than 2/3 of the serum glucose. The composition. So what are the consequences of altered CSF dynamics? What it can be: abnormal fluid movements, effect of raised intracranial pressure, circulatory changes such as ischemia, changes in brain morphology and parenchyma, changes in CSF circulation paths such as in obstruction due to any infection or tumors. Now, raised intracranial pressure management on the basis of the medical management and can be surgical managements. So, medical management takes time to decrease the intracranial pressure, and surgical pressure, if surgical procedures can decrease pressure in emergency and quickly. So, if patient is moving, having good consciousness, and just came for decrease of vision or headache and found to have raised ICP, then we can first try for the medical management. And if patient is coming to emergency in obtunded condition, low GCS, continuous vomiting, so we will offer first surgical management because it can decrease intracranial pressure more quickly than medical managements. So here are the example of temporary procedure: external ventricular drainage or the spinal tap, surgical management, shunt, endoscopic third ventriculostomy. Medical management by acetazolamide, that is the carbonic anhydrase inhibitor, 250 milligram TDS is the general dose in adult of 60 kg, but we have to monitor it causes acidosis in some cases, so we have to monitor. So that is why it cannot be used in the long terms. Diuretics, weak diuretics can be used, that is Lasix. So what happened in an emergency when a patient came with low GCS with complaint of diminution of vision and low GCS, and so first off we perform a spinal tap. So what information we can have from the spinal tap? For the spinal tap we can have the pressure of the CSF and the consistency or color of the CSF. From that we can understand, is it an infective cause that caused the raised intracranial pressure, or a non-infective, that is obstruction or anything other. So this, all you know that we can perform it in the sitting position or in the bed by under sterile precautions. Lumbar puncture needle is entered in the subarachnoid space, usually at the level of 3-4. The level is decided that because of the cord ends at the level of L1 or L2. So we have to below than the length of the spinal cord. These are the radicals from the spinal cords. It can be done in sitting or in lateral position. So these are the normal findings or the pathological findings in certain diseases or the conditions. So when patient come in emergency, we do as first a spinal tap to rule out whether it is a infective or a non-infective cause. Bacterial acute bacterial meningitis In case we do EVD and if it is a tubercular or viral, we can perform a directly ventriculoperitoneal shunt, because these can acute bacterial meningitis can lead to a peritonitis. So at that time we have to perform the external ventricular drainage. So normal CSF, what are the finding? Pressure could be 90 to 180 mm, and the WBC is 5, protein is 15 to 45, glucose is 2/3 of the serum, and chloride is 116 or 15. In bacterial meningitis, the CSF appears turbid, the pressure is increased, the TLC must be high, and due to the infection or the WBC, they secrete protein, so the protein level increases, and they eat up all the glucose. So then the sugar must be less than 2/3, and chlorides are also decreased. In viral meningitis, the appearance is clear, pressure may be normal, WBC slight increase in WBC, but protein are normal. They do not eat glucose, so glucose is also normal, and chlorides are also normal. In tubercular meningitis, most of the patient in our country is infective cause belong to the tubercular meningitis. So the pressure is increased at the prick. Then if we collect the CSF in the vials, there could be a cobweb formations. There are 100 PM, mostly polymorphonuclear cells are seen in the tubercular meningitis, and in bacterial meningitis, polymorphonuclear cells are more. In tubercular meningitis, lymphocytes are more. So sugar can be usually decrease, and protein can be normal to increase, and least common in the Indian subcontinent are the fungal, and syphilis is also decreasing now these days. So mainly we are encountered with the tubercular meningitis and bacterial meningitis, and on the basis of the WBC and what type of white blood cell, that is a PMN or the lymphocytes, we decide the tubercular meningitis or the bacterial meningitis. And in case of the bacterial, we have to perform the external ventricular drainage first to decrease the bacterial load. The protein counts is raised, that cause the frequent cause of the blockage of the external ventricular drainage. So now the second topic is the causes of the raised intracranial pressure. There are usually hydrocephalus, brain tumors, meningitis that we discussed, head injury, and a stroke. In this lecture, we are going to discuss hydrocephalus and the brain tumors. So hydrocephalus, it can be congenital or acquired, and enlarged ventricle if communicating or non-communicating. Non-communicating means obstructed somewhere. In communication, no obstruction of the CSF flow. It is a special type hydrocephalus that can be normal pressure hydrocephalus or idiopathic intracranial hydrocephalus. If the absorption of the CSF is obstructed at the level of the granulation tissue, arachnoid granulation, it is called communicating hydrocephalus. So need diversion. In non-communicating, there are obstruction in the flow anywhere. Usually there can be obstruction. Most common congenital obstruction is acute ductal stenosis that can lead to non-communicating hydrocephalus. The diameter of the aqueductus sylvius decreases, so there is ballooning of the lateral ventricle and the third ventricle, and fourth ventricle appears normal in that cases. And at communicating, the total path is normal, but there is pathology that is at the level of the arachnoid granulation, so there is impending absorption of the CSF at the level of venous sinuses. So it can be congenital. Congenital usually acute ocular stenosis. Patient present immediately after the birth with a complaint of increase in head circumference, a decrease in ability to feed, excessive cry, not gaining weight because of not having breastfeeding. And acquired can be infective or neoplastic or idiopathic also in case of special type idiopathic intracranial hypertensions. What is hydrocephalus? Is like abnormal accumulation of CSF in brain and cavities. It may or may not cause dilatation of the ventricle with egress of fluid around the ependyma. This is a type of the brain edema, interstitial edema. So, from this picture, the white thing outside the ventricle is the egress of the CSF due to the increased hydrostatic pressure inside the ventricle, is suggestive of hydrocephalus. So, hydrocephalus can be may or may not without the dilatation of the ventricle, but there is interstitial edema. If the presence of interstitial edema is there, then we can name it as hydrocephalus. So, what are the signs? Headache, vomiting, diminution of vision, diplopia. In children, it is listless. Child cries every time. Difficulty in feeding and enlargement of the head. So, this is a image of a baby. How we can measure? In less than 1 year of age, we can have anterior fontanelle open. So, on the basis of our anterior fontanelle clinical findings, we can also suggest can be also suggestive of hydrocephalus. A tense anterior fontanelle is a feature of raised ICP. If it is a lax and pulsatile with each heartbeat, that is a normal fontanelle, and it can bulging also. So, we have to have a quantitative data. We usually ask patient, family or parent to have head circumference twice a week. The way of measuring head is it is over both frontal eminences and cover occipital eminence behind. The measurement should be at the same level each time. This is the main thing. It should not be one time here to here and other time here to there. It must be measured in always on a same line, which can be compared with a Indian pediatric charts. At the birth, usually the head circumference is 35 to 36 centimeter, and if it is increasing inside, we can have clinical findings from the anterior fontanelle and from the increase in the head circumference. Then the last topic is the brain tumors. So, how patient can present with the history of headache, seizure due to that tumor, vomiting due to the raised intracranial pressure, diminution of pressure, diminution of vision due to the raised pressure over the optic nerves or direct compression of the nerves, or the paresis in one side of limbs, contralaterals. So, this is just how you can orient for MRI. This is a T2 images, this is a T1 images with contrast, this is a DWI images, and this is a FLAIR images. FLAIR, it is the inversion of the T2 images. So, in inversion of the T2 images, the findings of the CSF is subtracted with edema we can have. So, this edema is due to the tumor and this edema is due to the hydrocephalus. and this is the mass which causing the mass effect, also causing deformation of the ventricular system, decrease the flow. So ultimately this mass and alteration in the CSF flow leads to the raised intracranial pressure. So procedures in emergency, what are they? The external ventricular drainage. It is usually we do in two conditions. This can be done on the bedside and immediately. Secondly, it is the main procedure for bacterial meningitis. So if it comes to be bacterial, we do this only, and if we need bedside decompression of brain by the CSF, so we use this procedure. The patient is lying on the bed in the emergency or in ICU or even on the trolley in supine position with the head up. We localize frontal horn of the lateral ventricle. It is usually about 2 cm from the coronal suture. We make a burr hole and insert a tube which usually hit at 4 cm inside the ventricle. Then we connected it with a bag that is at the level of ear. That is at the level of ear, the CSF pressure is we consider as a 0. So above that, if this patient is having more CSF, what we consider normal CSF is 20. Let us consider the ICP of this patient is 5 cm or 25 cm of mmHg. So this 5 cm of raised pressure lead to the flow of CSF from this catheter to the bag. So the inlet of the position of the bag of this inlet, we decide on the basis of what amount of CSF we want to clear from the brain to decrease the ICP. This can be done at bedside and immediately, but it cannot be maintained for indefinite period. It is difficult for nursing staff to take care, and some type of the catheter also have monitors at their tip, so we can also measure while draining the CSF the pressure also of the intracranial pressure, and some type of the catheters is also impregnated with the antibiotics, so we can have the benefit of that also. And the main and the advantage is also that we can have CSF collection from each day from the opening, so we can have the study that meningitis is getting clear with use of this ventricular drainage and IV antibiotics we are going that way. Everyday sampling we can have eye over the condition of infections. Is it going to be it is treating or it is not. And final is the ventriculoperitoneal stent. So in case of the tubercle meningitis or any other non-infective meningitis, we directly insert catheter inside the ventricle, and then it can be distal end can be put inside the intrathoracic cavity, in pericardial cavity, and most common usually in peritoneal cavity. So in this also we can have assess lateral ventricle from any point, that is from the frontal, occipital. We enter in the brain and then to the ventricle cavity, put a catheter inside, and then connected with the external wall that is lying behind the ear over the temporoccipital bone. So we can palpate the chamber and have little information about the working of the chamber. And then under the subcutaneous plane of the neck, thorax and abdomen, we enter in the peritoneal cavity and keep the shunt. So, what are the advantage of this? This is a closed system. So, uh, do not require any further uh, precautions in the post-op times or post-operative periods. Any slide or any question? Anything you want me to explain again? No questions? How many have seen any shunt patient in clinical posting? How many of you have done lumbar puncture?